Okay, my clock just flipped to noon on the dot. So welcome everyone. We'll go ahead and get started. I just want to let everyone know that we do record these sessions. So with your permission, we are recording. If you don't like that, then you can drop. My name is Kendall Brown. I currently serve as the president of South Florida HIMSS chapter. Welcome to our programs committee webinar, Digitize Access to Healthcare. We have an astute and high caliber of panelists and a moderator today, Paul Salmon from Pediatric Associates and fellow board member who will be moderating the session, as well as Patrick, Ganesh, and Dr. Shen. We look forward to hearing your knowledge and wisdom, and thank you for participating today. I just have a few slides and welcome announcements before I hand it over and we'll get into the webinar. HIMSS is a global organization. I think there's over 100,000 members now around the globe. South Florida HIMSS is currently standing at 1,835 members. It's a personal goal of our chapter to supersede 2,000 members. So if you're not a member, we encourage you to become a member. There is a nominal fee, and any of the board members can help you with membership if you have any questions or need assistance. This is the vision and mission, which is part of what we're doing today, is education on health IT topics. Oops, wrong way. I encourage you to get out your phone and scan the QR code where you can opt in for text messages, and we do not send too many of them, but they're friendly reminders about some of the South Florida HIMSS events and some of the things that we are doing. So please whip out your phone and scan that QR code, and we'll be in touch with some news so that you can stay in touch. Alternatively, or also you can follow us on LinkedIn, Facebook, Instagram, and we do have a YouTube channel where these types of recordings like today's will be placed so that you can go back and watch it as many times as you want. We are always looking for volunteers for the organization. We are a very active chapter and have lots going on. If you'd like to learn more, again, get in touch with any of the board members, but we are actively pursuing volunteers. I encourage you to add HIMSS National Conference to your calendars. HIMSS National or International is going back to Chicago, and it's been several years since we've hosted the conference in Chicago. The dates are April 17th through the 23rd, so make sure you have that on your calendars. We have just under a week left to submit for South Florida HIMSS Innovation Award. This is our fifth annual year of the Innovation Award. You can find details on our website and through the emails that we've been sending. However, it's a great way to get exposure, not only for you personally, but your organization. And the rules are on the application, and I encourage you to have a look at that. You do get exposure through the presentation, but also as we announce the winner at our annual conference, Integrate, on November 17th, you're given a nice, beautiful trophy and a prize that it consists of registration to HIMSS National in Chicago. Our next programs committee is an in-person event on September 12th, September 22nd, 11:30 to 1:30. I believe lunch is being provided at FIU Kendall campus on a topic, age tech, innovative solutions for elder patients. We have the CEO of ChinMed and a few professors, as well as some other members of South Florida HIMSS that will be presenting. We also will be planning a Meet the Board event that will be happening in either September or October. And our, I believe it's our 11th annual conference. It's a mini national conference, if you will, where about 300 health IT professionals come together. We are switching it to a new venue at the Nova Southeastern University Innovation Center. Very impressive venue with robots and 3D printers. So please add November 17th to your calendar. You'll hear lots more about that event, but make sure you have that on your calendars. A big thank you to all of our sponsors. We couldn't do things like this webinar today without our sponsors. So with that, I'm going to turn it over to Paul Salmon and kick off the webinar today. So thank you all again.
Thank you, Kendall. Great introduction. I hope everyone scanned that UR code because you want to stay in touch with all the programs that we have in South Florida. So welcome again. My name is Paul Salmon. I'm Senior Vice President of IT and Pediatric Associates. We are a large pediatric focused practice in 5 states across the country. We have about 200 sites and about a little less than 2,000 providers. And real excited to be here and moderate this very interesting program. We have 3 really top-notch panelists. I'll tell you a little bit about myself, and then we'll go around and have the panelists introduce themselves. Pediatric Associates, like I said, we are focused on pediatrics, children, and especially during COVID, we've really excelled our telehealth and other digital access, our patient portal. We're doing a lot of things, digital registration, pre-registration, scheduling. We're rolling out scheduling so you can schedule your appointment online with your phone. You can come in and fill out all the applications and all the forms, all digital. So our telehealth does a lot of different things, but we have a large value-based program and about 600,000 lives in Florida alone. So we use telehealth to avoid emergency visits and allow the parents to be able to talk to a doctor and treat the children 24 hours, 7 days a week, and that's nationwide. So it's really good. It helps the parents, from panicking if it's not something too serious, but if it is, we definitely direct them and make sure they get the proper care right away. So we've had a lot of success for that. We've got a big team in telehealth. So I'll stop there and I'll let our panelists talk a little about themselves, their organization, and kind of how they're using digital access to healthcare in their scope. And why don't we start with Dr. Sen? Welcome, Dr. Sen. You want to tell us a little bit about your organization and what you're doing in digital health access?
Well, thank you for the introduction. Honored to be here. I'm a cardiologist by training, and I'm the founder and chief medical officer of Digitization Health. In essence, we're a hospital-at-home program. Actually, we're the first one as a cardiology-based hospital-at-home programs approved by CMS. So as you know, on the national level, probably 120 or so hospital-home program approved by CMS, but the super majority of them are hospital-based. We're not hospital-based. So what we do is we have agreement with insurance companies. They refer us a group of very complex and sick patients. And so we're gonna go to patient homes to see them, to monitor them, to prevent unnecessary readmissions, and provide a quality care. Patients like on ventilators, on dialysis at home, patient post cardiac transplant, renal transplant. This group of really sick patients. Actually, we just summarize our data. Average of readmission per year, about 5 to 6 per year of the patient referred to us. And I'm very happy to be here and share our experience and also learn from the panels. Thank you.
Great, thank you. Ganesh, do you want to go next?
Sure. Hi, everyone. Ganesh Prasad here. I work at Memorial Healthcare System in South Florida. I also sit on the board for the South Florida Hidden Chapter as the president-elect. I've been with the board for about 4 or 5 years now. My role at Memorial is I oversee our Connect program, where we extend our instance of Epic to other community providers and health systems in the area. I also lead our population health teams here from an IT perspective, working with our operational teams. And I also oversee our interoperability teams as well. Now, with respect to this topic, we're looking at operationalize the technology to help streamline access to care and that omni-channel capability for our patients or our consumers. So working on setting up an infrastructure, both technically and operationally, to help break down some of the barriers that exist with respect to access.
Great, thank you. Patrick Murta, you want to introduce yourself, please?
Yeah, sure. Thank you very much, Paul. I'm Patrick Murta. Welcome, everybody. Appreciate you coming to the webinar today. I am Chief Platform Architect at a company called Behavior. It's kind of spelled weird, but it really is pronounced Behavior. And the VR is going to be important in just a second. And our model is basically using proven science, such as cognitive behavioral therapy, digitizing that and turning it into immersive virtual reality experiences for folks with anxiety, depression, or substance abuse. So that's kind of our model. Proven science, digitize it with real outcomes. It is obviously a completely digital platform because we're taking protocols that have been developed since the 70s, digitizing those into experiences, and then serving them up in the headset, either as a wellness product or under the supervision of a clinician. We use everything from Azure backends, which again is completely digitized, web apps. Also, they are connected devices. So not only are they delivering the experience, they can use existing standards to send messages back to prescribers and basically play an active part in the healthcare ecosystem. As part of the panelists today, I'm going to reflect some of my payer experience as well. Before joining Behavior about 6 months ago, I did spend 25 years at Humana, where I was Chief Interoperability Architect. I'm also the Chief Architect of the ONC's Fire at Scale Task Force and a member of DaVinci, some of the other HL7 fire communities as well. I like to say that my mission and my passion in life is basically bringing digital experiences and digital solutions to folks that are in need and can benefit from those products. Thank you, Paul.
Thank you. Well, as you can tell, we have a wealth of knowledge here at your disposal, panel. Great. So let me start with the first question, and let's start with Patrick. So digitized access to healthcare has been a hot topic these days. I mean, it gets hotter and hotter. And for some time now, and things are really moving forward. Are things really moving forward, and what are the drivers and the direction those drivers are moving us to?
Yeah, and that's a great question, Paul. And again, I'm going to approach this mostly from a payer and device perspective, but having spent 25 years trying to move interoperability and digital healthcare forward, I can finally say that yes, things are actually moving forward. And 10 years ago, 15 years ago, maybe even 6, 7 years ago, I would have struggled to give a straightforward answer from that perspective. But a couple of things have really, from industry, from technology, from just partnerships in this space, have really come together to move the ball forward. I like to call it the inflection point. I know that's kind of a buzzword at this point. Have come together. First of all, the underlying standards, right? We've had APIs and digital ways of communication for many, many years and borrowed from many different industries. But the fact that we are starting to settle on a unique set of APIs and protocols from data models, which are semantically and syntactically interoperable, to API definitions such as FHIR under the HL7 organization is something that really allows us to build once and read. So that kind of provides the foundation. But there's also community and industry drivers that are pushing it together as well. For example, we talked about value-based care. I think, Paul, you mentioned during your intro, the fact that value-based care is the evolving model as it relates to payer and provider interactions, right? And it's easy to recognize, or should be, that unless you share information and digitally between those entities, you cannot fully recognize the value of a value-based care model, right? Because you're flying blind from a provider perspective. Same on the payer side, right? You can't really work in that model without sharing information. That's different than it was 10 years ago in a fee-for-service model, right? Data sharing wasn't that critical. Probably should have been, but it wasn't. But with the value-based care model, that changes things significantly. The regulatory impacts, the fact with the 21st Century Cures Act, we have CMS regulations, CMS 9115 and the ONC rule, which I can't remember that really long number, that basically is mandating that folks use these protocols to share information using these standards-based stuff. And the other thing, which I find is just remarkable, is that folks are actually coming together, literally, payers, providers, EHR vendors, research, whatever the case may be, helping to develop use cases and implementation guides and things that we can all agree on, that we shouldn't be competing on, because it makes no sense. It just draws efficiency from the system. But if we agree on formats and use cases and solve real world problems, that helps move us forward.
Great, very good. Dr. Sen, what do you think? What's the drivers and where do you think we're headed?
Yeah, it's a good review from the technology side. From the clinical side, I think you're right. We came a long way, and right or wrong, pushed by the pandemic, right? Before we started telemedicine, a lot of resistance from everybody, from skeptical, so patients, the providers, right? But the pandemic pushed us. We have to deliver this in order to minimize the problems, right? From my perspective, I think there are 6 areas that from the clinical side is essential, which enable us to do the digital delivery for the digital access of patient care. So number 1, as we mentioned, is the telemedicine, right? We enable us to see patient face to face and to deliver the service. The second is we need to check on patients, right? When we want to see the patient, we need to check vitals. We need to know what's happening remotely, right? So that's why all the CCM, RPM, this platform developed and enable us to check on the patient. So we know that's the first thing when you see patient, right? The third is there's some special monitoring. So for example, I'm a cardiology, and what I like to see is EKG, right? So if you have chest pain, you have arrhythmia, and some pulmonologists might need a pulmonary function test. So we need to have some specific parameters in relationship with the patient presentation and the problems we try to solve, right? Another thing is the data, right? You guys talk about how we can use different systems to put all the data together to connect the backend of all these systems, make a standard and interoperability. The next one is the EMRs, right? So, you're right. So 10, 20 years ago, it is, very challenging to put all these things together. But EMR provide a solid foundation, enable us to put all things together to do it. The last one, I think is the key, is how we can track our success, how we can get feedback from among the patient, from the clinical outcomes, financial outcomes, and saving, right? So we need to really overview and criticize ourselves and have we make progress, which areas we do better, which areas we are not yet, and how can we improve ourselves. So this we really complete all this digital ecosystem, allow us to improve and do better job. Thank you.
That's great. Ganesh, what's your thoughts on this?
I agree with everything that Patrick and Dr. Shen said. I mean, being in the provider space, the hospital space, I mean, we're living and breathing this every day, right? So, with respect to where the industry is from a standards and regulatory perspective, I agree with Patrick. We've come a long way, right? And the fact that you have the federal I guess rules that are helping drive some of the change where, back in the day you had everyone was kind of competing against each other, whether it was an HIE or, healthcare organizations not wanting to share information with payers, right? The dynamic, the culture change is already happening, right? Where we're seeing that exchange of data to and from different organizations that we typically had reservations for. So I think that's a benefit in and of itself. When you look at the use of the data, right? So sharing the data is one thing, but when you're bringing in that data into your workflow, into your clinician, you know, fingertips, right, where they can drive decisions and outcomes, and you know, we can create, you know, some type of predictive modeling and stuff based on the data that we bring in. It's key, right? So I think with all that data that we have in the system, obviously, you know, what you do with it is up to the organizations, right? So driving those clinical outcomes, I think, is one of the benefits. So what Dr. Shen covered, you know, when you look at, you know, RPM as an example, right? We're bringing in this data real time for patients, whether they're on a blood pressure cuff, an EKG machine, a pulse ox, you know, what are we doing with that, right? Are we operationalizing care management or clinicians to monitor those patients real time, right? To intervene, and it all ties back to the value-based care proposition that all healthcare organizations are facing now, right? Is what are the outcomes? How are we impacting those patients? How are we reducing readmissions? Especially now with CMS and having like the bundle programs, right? That they have, right? A lot of organizations that are participating in those programs are largely at risk. So from the provider perspective, having that synergy with the technology, the operational workflows, I mean, we're going to drive change and then ultimately, you know, increase patient satisfaction.
Very good, very good. So in summary, and I agree from pediatric, you know, ambulatory point of view, value-based care is a big driver, you know. So connectivity, interoperability with the data. I think just to kind of look at the future, though, I think a lot of us, you know, wonder what that's like. I see, at least, especially from an ambulatory practice perspective, the smartphone and maybe even the VR devices will be an extension of the doctor and the practice. And we're experimenting with some of that, especially with behavioral health. Monitoring, the panelists mentioned monitoring, remote monitoring with connectivity with devices and so forth. It's the future is virtual, I believe. So there's a lot of parts to that. What I'd like the panelists to do is talk a little bit about the value-based care factors. How does drill down a little bit more into that? I know we've all touched on it, but how does that drive it, and what does the future look like in that world? And let's start with Ganesh this time. Let's reverse the order.
Yeah. So I think, you know, I touched upon it a little bit in my last response. You have the requirements that are being set by the regulatory bodies, right? And, you know, now with the partnership with payers and so forth, you know, they're holding us the standard to provide, you know, superior caliber quality care for the patients. And then obviously there's a direct financial impact to not doing that, right? So I think with putting all the technologies in place, whether you have an RPM program, right? And RPM's been around for a while. I see Dr. Eric's on the line. You know, it's now it's a sexy thing, right? As far as everyone wants to do it. Everyone wants to be able to have a program to say they're monitoring patients, whether remotely or whether they're doing device integration for their telehealth program, right? I think the value proposition for, and I'm speaking for what we're doing here at Memorial, is if you have those technologies, rolling it out in a manner that is going to benefit the organization. So not just doing RPM for your chronic patients, right? But looking at your employee base, looking at your community providers that are out there, right? Who could benefit from utilizing a solution like that, and coming up with a program to to not just look within the four walls of the organization, but span it out to other areas as well.
Great. Dr. Shen, do you want to comment on this?
Can you hear me?
Yes.
Okay. Yeah, so from my side, from a clinical point of view, I really think the value need to be defined from two aspects. One is the quality of care. Another is the cost of care, right? So, this has to be improved simultaneously. And this is a lot of people are saying is very hard to achieve because this is not on, the business books, textbooks. Usually the reverse relationship, you want to have high quality, you have to pay more, right? But we see, the Amazon model, right, which is make them a $1 trillion company, only 5 in the world. And they do a better quality, better availability, at least, and a much better cost. That's why we make a shine. I really think that's the healthcare need to do. It's very challenging to do, especially in this era of lack of personnel and providers with the pandemics, right? Nursing shortage, physician shortage, provider burnout is very challenging. That's why I think we need to innovate and to utilize technologies, how to effectively capture data and deliver better care. And then at the same time, we have to lower costs. Otherwise, this model is not going to be sustained. Thank you.
Great. Okay. Patrick?
Yeah, thank you, Paul. And I totally agree with what Ganesh and Dr. Shen said. So I'm just going to riff on that just a little bit. And I saw something pop up in the chat about patient being at the center. And I think with the aspect
that was
of
my next
digital
question, Patrick. Wait a minute. That was my next question.
Okay, I'll just go quick that with digital tools, we go towards the center with the patient. And I'll give an example here. If we talk about value-based care and devices, I'll keep it simple there, is that in the first iteration of value-based care, the fact that we could share data and figure out, okay, who was laid on their stars and what the HEDIS scores and what the quality measures look like, and you can manage your population, right? That was the first level. The second level of digital integration there goes much beyond that. And that's the fact that using devices or VR or whatever the case may be, it's more monitoring. It's actually actively monitoring what's happening with the patient, right? Either self-reported through interactions or directly from devices that are on the skin or whatever the case may be. It takes it to a whole new level. Not only are you doing it just for analytical purposes with sharing of information and in-person experiences, but you now have the connected system that's going through devices and providing information that can be monitored in close to real time. So it's a whole new level of monitoring, ensuring that the outcomes, which are the promise of value-based care, are truly being achieved.
Right. Okay, so we've talked about drivers. We've talked about what it is. We talked about some of the functionality. There's other pieces to this, right? We've got the data side, integration, interoperability, and then we've got our patient. And we've talked about provider too. So why don't we talk about now what this means to the patients, to providers, the members. And Patrick, since you mentioned it, why don't you start and how does that benefit our patients, our population?
Yeah, so the digital environment that we're talking about provides the foundation for patients to take control of their data, control of their health, and truly become the center of the ecosystem, right? But it also, from my perspective, is the most challenging because it's a complete paradigm shift from how healthcare has traditionally been delivered in our country, right? And the fact that we are delivering tools, we got apps on our phones. With the CMS 9115, we've got patient access APIs are required, but we're seeing that the adoption is still fairly low. It's very extremely low, actually. The fact that, we've got, now that the technology's there and the actors such as payers, providers, research, whatever, is really diving in and moving forward, we need as a group to come up with a plan to ensure that patients are coming beside us and not just the 2 or 3 or 4 or 5% or 10% or whatever that are using those types of apps, or they're truly the outlier. And for the technology to truly realize its vision, and improve outcomes at the level that we need it to, it's got to have the patient at the core, right? So it goes beyond just a technical play at this point. It's how do we, how do providers encourage their population to start using some of these tools via prescription for therapeutics? How do payers engage, right? One of the things that looked at is making perhaps some of these technologies part of a value-based care portfolio, right? So if you're in a value-based care arrangement, you get a device. These things are not that expensive, $300 on Amazon, right? So, and if they're part of a package that a payer is, representing, or that part of the contractual thing, or whether it be some other device that Dr. Shen was referring to, actually baking those into the value-based care arrangements helps move that forward.
Very good. Dr. Chen? Let's talk about the patient side. How does it interact with them? What's the barriers to this technology? Let's talk about that too. What's the benefits and the barriers?
Yeah, I think the key of the digital delivery and access is we need to have a better understanding of the patient, right? What's the individual patient, what they need. For the general population or population health management, which is good. Basically, we have minimize all the risks, right? And monitor them using CCM, RPM, and check cholesterol, the glucose. They're all good. But to me, if you look at the cost, right, the 550 rule, meaning 5% of population account for 50% of healthcare costs for last 2 decades. That's really challenging. From that end, I really think the digital is the only way to be individualized, customized of this population. Sorry, got my batteries. So from that end, we need to have much better understanding what patients are. So I can give you a quick example. This is patient actually is the very first patient referred from a Memorial, right? So Memorial doing great work and keep the patient alive. He's really sick. He had 13 admissions during 12 months before come to us. And we're not talking about risk factors. He had heart attack. He got stent, bypass surgery, got defibrillator, 2 mechanic valve, and renal failure, COPD on oxygen 24/7. The last admission walked to the ER from Memorial. He had a cardiac arrest. The nurse jumped on him, start chest compression, and the nurse get a shock from his defibrillator. Intubated, stay there for 2-3 weeks. At the discharge, they told him, and sir, you have 2 options: either go to hospice, right? You're so sick, or you go to nursing. And he doesn't want to do any of this, right? So when we receive patient, we didn't know what to do, but we learn, right? We interact with him and learn with him, right? So actually this month, we just celebrated his 6th year anniversary, right? The guy is still standing strong, but we aggressively monitor him, learn from him, and have him to teach what his body looks like, what his cycles, and then we can monitor, we can respond, we can catch before he goes down, right? So over this 6 years, and he had 1 admission, but that was COVID. It's not related to heart failure as I had before. And actually his pulse ox went down. I sent somebody to a house and check him. He's positive. I will send to a Memorial and save his life, right? So I think the key is we need to look at the patient individually and learn from the patient, right? Rather than say, we have the system, the process, you need to fit in with one of our assembling, right? So that's for majority patients good, but for some of this really high complexity patient is not going to work. But the digital process, technology, and our innovation, right, can make this happen. Thank you.
Excellent. Thank you. Ganesh, what do you think?
Yeah, the patient, I agree with Dr. Shen. It's largely a trust factor, trust and relationship factor from a clinical perspective, right? So I led our implementation here for our RPM program. And obviously the technology is honestly the smallest component of that program, right? When you look at the clinical workflows, right? The one thing that's in common with the different service lines that are using the RPM program, whether it be our primary care provider group or our pop health care management group, the one thing they have is a relationship with these patients, and not just oh, hey, you're a patient that's assigned to me and I'm going to monitor you. They know these patients, they talk to them almost on a daily, weekly basis, and they have that trust factor, right? So the adoption of whatever the technology is, I'm using RPM as an example, but whatever the technologies that we're asking these patients to participate in or use, right? They're going to be more susceptible to adopting it and using it because they trust their providers. They trust the clinicians that are going to take care of them. And for me, and obviously we're seeing it, and we're seeing these patients who are avoiding readmissions, who are avoiding, going to the urgent care because we're catching those events real time and intervening. And we've had very successful patient testimonials as far as, you know what, I was going to go to the emergency room, but because you called me and a clinician was able to intervene, right? And what is that? Going back to your prior question, the direct correlation there is the value-based proposition, right? So you're gonna save with that. And so what Patrick said, I don't think the payer and the value-based arena is not everyone's there yet, right? Because when you look at value-based care and you have healthcare organizations that are having these programs in place, right, billing becomes an issue, right? Because now you're saying, okay, you have a patient that's participating in a program, and yes, there are CMS rules and compliance rules that say you got to bill for it, but now your reimbursement contracts with these payers aren't necessarily up to par to cover that cost, right? So now you get into the payer aspect of it. Now, well, the clinical aspect is great. This program is showing outcomes. Patients are happy, right? Our program is successful. Now, if we start billing and these patients are getting copays, they're more than likely not going to want to participate in it, because when you look at the base of patients that you have, they're probably critical patients. I mean, high complexity, various social determinants of health that might have insecurities for financial or whatever it may be. And they'll be like, you know what, I can't afford this $5 copay, let's just say, whatever it may be, because I need to put food in my table. So that, I know I'm shifting a little bit, but there's the whole social determinants piece of it where that comes into play. But if organizations and payers structure their contracts in a manner that mitigates that, then I think the adoption is just going to be, widely adopted.
Yeah, excellent. So I'll give you a real world case here. In the last 6 months or so, we rolled out Digitize pre-registration in a number of practices. And of course, our population, children, younger parents, right? So, they're more tech savvy, but again, some of them are part of a, population that requires a little more care than others. But the success was very well. We've got over 90% utilization. So 90% of the patients, 80% of the patients did the forms and the pre-registration and the assessments before they got in the office. The other 10% did it when they're in the office, and then the rest of it, the less 10% went back to the paper. But then we did a satisfaction survey on all of them, and the people that used that loved it. I mean, when you're dealing with a sick kid or you're going in a well visit, you don't want to have to deal with a bunch of papers in the lobby while your kids are running around. So they really like to be able to do that before they got there, when there's a nap or they have some time on their time schedule. So Digitize in those examples were a big benefit to the patient. There was big incentive there and great adoption and satisfaction. So just another use case. Let's talk about the other leg of the stool, so to speak. What about data? I mean, for all of this digitized, you need a back-end data, you need interoperability, you need data from multiple sources, especially for value-based care. How about sharing data between the different spectrum of healthcare, different continuum of healthcare, to have a whole picture of the patient? Because if you only have a part of the data set, right, and you're offering that to the patient as a digital front door, it's what's that worth? So how do we get a full data picture of our patient health? Patrick, why don't you start?
Yeah, that's the $64 trillion question, Paul. And I think, we as somebody that's been doing this for a while, with my peers here, it is something that we've taken different approaches to over time, right? The thought of having a single, and I think one of the large merged organizations recently brought a thought back to life about having a massive database in which everybody's data is centralized. I personally think that's not tenable, at least in the near term. So the approach, that I've been advocating for, and I think is gaining ground, is the fact that is if we can advance interoperability, right? And I hit on this kind of in my introduction with some of the standards that we're working on with HL7 and other standards organizations, so that information can be virtually available as needed, right? It may not be stored in a central database, but we've got APIs and other types of interoperability that makes it available. It really gets close to solving the same problem, right? So that information that's available at the appropriate workflow, for the appropriate reason and driving the right outcome. So there is a lot. I like to say that if you look at the world of interoperability, the APIs are really the easiest thing to do, right? Because they're predefined, and we've been working on these from an industry perspective for a long time. Some of the things that really need to be focused on are the democratization and liberation of data from backend platforms, right? Because we've got systems that until the last couple of years were not designed to be interoperable, right? They were designed for, clinical systems that were siloed, or payer systems, or whatever the case may be, that were using different underlying technology. So the work to start liberating that data and democratizing it and making it available with the appropriate consent and appropriate security, of course, across the ecosystem via HIEs or, some of the newer standards as well, is something that I think is key. Do we have a ways to go? We absolutely do. But a lot of really good, healthy work is happening on making sure those standards are defined. People are coming to the table, and some of the, the work groups across the spectrum of healthcare. And also, as we noted before, the federal government is totally on board and has started mandating the use of some of these technologies to share information. So I think we need to just keep pushing that model, and all the complementary stuff that we've been talking about. I see digital twins, which just keeps popping up, and I love that topic. So we have to do another webinar just on digital twins, but continue to move that forward from an interoperability perspective is going to help us solve that problem.
Yeah, I agree. You and me both. So for one, that was one of the panel or team that wrote the first HL7 and operation manual way back. I won't even say what date that was. This has been going on for a long time, and we made some progress, but we have a long way to go. So, Dr. Sen, what do you have to say about interoperability?
Yeah, I think you're right. And from technology point of view, we made a lot of progress. We set up the standard and build up the infrastructures, the communications. I think right now the bottleneck is really in the implementations and the adoptions, right? So it will take a much longer time to get the paperwork signed, get all these process. Then the Ganesh group, technical, people can put together, right? So I think this, we have to bring everybody on board, and if we're gonna share the information, everybody win, right? So, but a lot of people still say, well, this is mine, and with that mentality, is very hard and to work well in this new environment of value-based care. Because nobody, it doesn't matter, a small organization like us or a huge organization memorial, right? But we need to share information. Otherwise, how can I know what happened to patient, outside, inside, finance, and, the patient, the social determinant. So everybody have to work together to contribute, right? Then we can really share the data, then everybody will have much better understandings and a better improvement.
Yes, absolutely. And before I let Ganesha answer the question, I also want to say the Memorial is one of the best organizations to work with interoperability and sharing data. So I just want to point that out. It's on the recording. So go ahead.
I'll hold you to that, Paul. I'll hold you to that.
No, you have to hold yourself to that.
Yeah, we've come a long way with respect to interoperability, but obviously the industry has lended itself to doing that, especially in the state, working with our partners with, the Florida HIE, getting the connection to probably one of the more interoperable states in the country. And it wasn't always like that. So I think, partners like Pediatric Associates and others to help drive it forward in the state has put us in a really good position. I think just to add to what everyone said, when I look at the industry and like I said, where we've come from, we've come a very long way. I think the future, looking at what ONC is doing with the 21st Century Cures Act, with that notion of putting the patient at the center of their own care, and pretty much forcing organizations, right, to share that information and have it be available to the patient, right? I think that was a culture change for most organizations. And then looking at what is coming down the pipe with the HIEs with respect to TEFTA, I think they're gonna drive a lot of the standardization across the industry, where you have the everyone's following different standards, and seeing the collaboration with all of the EMRs. Recently I was on a conversation with some of the national players talking about the 360X standard, right? And that was pretty much, you had all the big name folks in the industry come together and agree that they are going to follow the same standard for being able to exchange referrals, between EHRs. Sadly, right now, currently, not everyone does that. And then when you look at what's going on with respect to the social determinants of health process, right? I'm not going to say it's a buzzword now, but everyone is trying to streamline and operationalize their social determinants of health efforts at their organization, whether they're establishing a DEI, governance group. But when you look at it from a technology standpoint, you have the Gravity project that is looking at tapping into the interoperability framework, right? Using standard ontology, SNOMED, loin codes, G codes, right, for social determinants of health, to be able to share that, right? Because, if you have a patient that's coming in from New York and they have a social determinant in need, right, and they're coming down to Florida to visit and they end up at our facility, you don't know, right? Right now, everyone's kind of operating blind. And I think with that standardization, it'll drive change. So again, the data piece of it, I mean, you can have it, right? But what do you do with it? What are you doing to drive an impact change for your organization and ultimately the patient, right? Going back, the patient is the center. And then tangentially, you have we talked about it, the value-based piece of it, right? So if you get external data for patients who have care gaps that need to be closed, right? If you get that external data, you can say, hey, this care gap is closed because I'm responsible for this patient. And what does that do? It probably prevents a provider from ordering a duplicate test, reordering a test, whatever it may be. And there's that, obviously that results in a cost saving. So again, the data is key, but how you use it and how you operationalize it is what's going to be the driver.
Great. So Ganesh mentioned the 21st Century Cures Act. Let me ask the panel a question about regulatory support on this, right? So, we've got the, we all want to do the best for the patient, but what is government, local, state government, federal government, ONC, CMS, et cetera, what's their role in this? How do we, and being the co-chair of advocacy is a hot button for me. What can we do to help get this data, free the data, right? Make it interoperable, make us be able to do the things we really want to do and improve healthcare and reduce the costs and have these incentives. Patrick, I'll let you start.
Yeah, thank you, Paul. And that question is, I don't want to say the word loaded one, but it is always one in which, too much regulation, not enough regulation, that type of thing. So I'll frame it up from a very positive perspective first, and that I think we're very fortunate that both CMS and ONC, in response to the 21st Century Cures Act, and even before that with ONC, with meaningful use and other types of things, have tried to lay or provide incentives and also a level playing field for folks to use standards to share information, right? In an ideal state, that wouldn't be necessary. Would all be adults and realize that we need to share information without dealing with, the organic dysfunction that historically has impacted healthcare with animosity and distrust and stuff like that. But that's not the world that we've lived in. It's gotten a lot better, but that's not the world that we've historically lived in. So I think having CMS, which, you don't always jump up and down with joy when you see CMS regulations. I absolutely did jump up and down with joy when I saw CMS 9115 mandating the use of a standard that I'd, helped evolve for many years. Because it did a really, really good thing. It put patients at the center of their data, right, by giving them the authority to get information from payers, right, with the click of a button on a third-party app. But it also required that those payers who may have been hesitant to jump into the world of contemporary interoperability, which we all recognize makes it better for all of us, required that they build an infrastructure to share information. And once the investment is made, then you tend to reuse the investment for other use cases. And that is kind of the networking effect, right? So you're starting to use that more. The same with ONC, right? The fact that they are trying to incent folks and provide, models and approaches or recommendations or advocacy with TEFCA or some of the other things that they've come up with to help incent people to share information so that it's, right data, right place, right time for the right outcome is very, very good, right? We would like to get to a world in which we did not have to have regulation to get to the point of sharing this information, but that's kind of where we are now. So allowing it to provide incentives, the framework, the groundwork for all of us to share data, I think is a good thing. Hopefully, as the industry matures, we'll need less and less of that. But at this point, I think it provides value.
Patrick, you're an optimist. I love you. Dr. Sen. What do you say about regulations?
Yeah, I agree with Patrick. This when you look back, I remember 20 years ago when HIMSS just started, and so EMR is like big thing, right? And but with the high tech, regulations, they really push significant fundings to build these foundations of EMR, right? That's really set up the precedent for all this data, communications, analytics, right? Before everything paper, we're not talking about nothing, right? So now after this, and to me that's hardware, right? So you have after you have hardware, now you need the software and you need the data communicate. So this is another milestone from there, but it's significant. Otherwise, without this regulations and requirement and push, and so we can't share data, then we become still the isolated silos, and there's no way we can operate, right? Especially, the value based, it's total different requirement, total different of the customer, needs, And this is a must in order to achieve that goal.
Great. Ganesh, did you have anything more to add?
No, I think everyone's covered it. I'm just looking at time.
Yeah, so we've got about 5 minutes left. I want to make sure that anybody in the audience has an opportunity to ask any questions. You can ask in the chat. Probably be the best way to do it, because I don't think we want to take everybody off of mute, or raise your hand. I'm not sure, Vanessa, how we want to kind of do this.
Yeah, there's been a lot of chatter in the chat, trying to see if there's questions, but
yeah, there's a lot of great comments here. I'm trying to tease out the question that we haven't covered yet. So there's one here from Tom about incentive. Let's dig into that, because it's an interesting comment he makes. Patients are not always incentivized by better health, and other incentives, financial, adoption, etc. What do we want to? How do we talk about incentivize for digital access? Dr. Sen, do you want to start?
Yeah, that's interesting. So ideally, let's put a scenario. Say, well, if the patient want to motivate, right, stop smoking, eat right, communicate with doctors, and do the right thing, and that'll be the ideal, right? Then we enable the patient, give them all these devices, then they can communicate, right? Right now, that's not the case. So how we're going to make it happen? So as you guys know, probably know more than I do, we need to have a system incentivize all these people financially, whatever is going to be, right? Right now, the patient's not. This is I really see there's holes in the system, the process, right? So the patient said, well, that's all I pay. I already got the insurance card, and if I go there once, twice, tomorrow, next week, I pay nothing, right? So then, therefore, there's no, incentives for the patient and compliance, right? They continue smoke. At the same time, you say, well, you need to take care of me.
Right.
How do you get that done, right? So I have people, we order medications, and we find out, there's no response. We call the pharmacy and say, what's happening? Oh, they haven't picked it up yet.
Compliance. That's
right, exactly.
Big thing.
We need to have some sort of regulations to push and say everybody need to participate, right? The providers need to participate, the system, the technology participate, the health system, the hospital system, and the patient, right? So we have to synchronize everybody's effort in order to reach the goal effectively, efficiently. Otherwise, it's just it's very challenging. You do your thing, they do their thing. How are we going to reach the goal? It's not the same goal, right?
Right. Yeah. Ganesh, you have any thoughts?
Yeah, I could. When you, just to add just a little bit, when you look at society, right, and you look at the Amazons of the world, and there's that reward component, right? Or you have a reward card for everything. You get reimbursed for something, right? When you look at some of the incentives that can come out of these programs and the adoption, I think incentivizing patients to be able to be compliant, saying, hey, if you do this, you'll be entered into win something or get a gift card or whatever it is. And I had mentioned my comment here to Tom. I think, CMS allows for some of that for certain circumstances, right? But, it's not, you have to be careful when you do that too. So I think it's that balance.
Okay, Patrick, 1 minute.
Yeah, and I think, and I'll just hit it from a technical perspective. I think Dr. Shannon Ganesh nailed it, is that, from a Web3 blockchain perspective, although it's not going to be tomorrow, not next week, not next month, the fact that, a lot of organizations, including myself, are looking at adapters that allow the platforms to communicate with external reward systems and other types of things that will get folks the reward can occur outside of the clinical experience, right? So although I think there's still a lot of work to do, it's kind of working in a lab at this point from our perspective, that at some point these systems and these devices and other types of things, rewards will happen in a Web3 type environment.
Very good. Rewards and accountability. You have to be accountable. Can't be smoking and drinking and doing bad things and then expect good health, right? Well, we'll end it there. I know there was a question about clinical decision support. I think we'll definitely have another program on that. That's a good one. Thank you all for joining. I hope this was valuable. I thought it was great information. We had top-notch panelists here. Really, really interesting stuff. So thanks, everyone. Look for other programs, South Florida HIMSS. If you're not a member, sign up, get all the benefits.
Thank you all.
Thank you all.
Thank you.
Thank you.